Diagnosis of IC-BPS could be very challenging because there is no specific investigation which can clinch the diagnosis of IC-BPS. So basically the diagnosis is symptom based. So a patient who has frequent urgent voiding which is driven by pelvic or lower abdominal pain and which increases with the bladder filling and the patient gets relieved after voiding, that is very typical of IC-BPS. And by the symptoms only you can diagnose. The problem is that these symptoms can be mimicked by many other confusable disorders like urinary tract infection, then we have malignancy, bladder stone, gynecological disorders. So we need to exclude these confusable disorders to come at the diagnosis of IC-BPS. So for excluding, we need to investigate these patients. So the two most important tests are urine routine examination and a urine culture sensitivity, because urinary tract infection is the most important differential diagnosis of IC-BPS. So once you have done a urine routine examination and if you find there is microhematuria or if the patient is a chronic smoker, then we need to do a urine cytology also in these patients. And if the history or physical examination suggests, we might do some special cultures like a fungal culture, chlamydial culture, a prostatic fluid culture, a vaginal swab culture, etc. So these are the basic tests which we need to do. We need to also do an imaging study because some of the disorders can be missed on history, physical examination and a simple urine routine examination. So an ultrasonography of the lower abdomen would help us to pick the bladder and the pelvic pathology. And later we may do some advanced imaging study if it suggests. A urodynamic study could be done in these patients, though not mandatory, in patients who have obstructive urinary symptoms or who have a poor detrusor contractility or with overactive bladder. A cystoscopy could be done, though not necessary in all patients of BPS, but this will help not only to rule out some of these confusable disorders like bladder stone, BPH, malignancy, etc., but it will also help to support the diagnosis because the stigmata of IC-BPS in the form of glomerations or Hunner's lesion can be picked on cystoscopy. And the cystoscopy could also be therapeutic in the form that we do hydrodistension or fulgurate the Hunner's lesion that will be helped by cystoscopy. So these are the basic investigations. There is a lot of research going on to find out a validated marker, either a urine based or a blood based marker which can actually clinch the diagnosis of IC-BPS and also help in the treatment progress. So one of that such promising marker is the anti-proliferative factor in urine, which is a protein which is detected in patients with interstitial cystitis. So if this becomes a reality and comes in clinical practice, then we can truly clinch the diagnosis by measuring this factor. There are other research going on in other factors also, but this is probably the most promising one. Thank you.